With respect to efficacy, we do not have much direct data on that question. A lot of older IBD patients have been excluded from clinical trials, and the data that we have looking at real-world efficacy of therapies in older IBD patients are mostly based on retrospective reviews of charts. Therefore, I will spend the majority of my time talking about the safety of the various therapies available for us to treat IBD. Number one, prednisone. Now, prednisone can have many side effects, and this is important, especially when we're talking about the older patient population, which may have underlying comorbidities that are exacerbated by steroid use. We know that there are comorbidities such as hypertension, diabetes, glaucoma, cataracts, osteoporosis, even depression and anxiety that can be worsened by steroid use. So how can we get around that? Sometimes we can, and other times we can consider using another type of steroid called Entrecort or Cortiment in ulcerative colitis patients. This steroid is known as budesonide, and budesonide actually gets metabolized in the liver quite readily, so that only 10 to 15% gets released into the rest of the generalized body. And therefore, the side effect profile is often kinder with Entrecort than it is with prednisone. The second medication is Amino Salicylates. Now, data has shown that over 2/3 of older IBD patient population, they are on Amino Salicylates. And it's probably because Amino Salicylates are fairly benign, they don't suppress the immune system, the oral pills are fairly well tolerable. However, in terms of safety, there are a couple things we should be mindful of, or even just practicality of use. The first thing is that the administration of rectal aminosalicylate therapy or 5-ASA therapy can be hampered in older patient population. It can be harder to retain for them due to compromised sphincter tone, as well as harder to self-administer. Number two is that there's a rare risk of interstitial nephritis or inflammation of the kidneys, and in a patient population who may have already issues with their kidneys or chronic kidney disease, this may be something to be mindful of. And lastly, aminosalicylate use can augment the therapeutic efficacy of azathioprine or Imuran, and therefore we need to be mindful of that. The next therapy is azathioprine or Imuran. And from a safety perspective, there are several things we should be mindful of. One is non-melanoma skin cancer, and so these include things like basal cell carcinoma and squamous cell carcinoma. And studies have shown that the risks of non-melanoma skin cancer do increase with age. And in spite of patients stopping taking azathioprine, that risk persists. Now, on the contrary, the lymphoma risk also increases with age. However, if patients stop taking azathioprine, then the lymphoma risk returns to the baseline population risk. Overall, if you want to give an overarching number for what is the risk of lymphoma in a patient on azathioprine over age 50, it's probably somewhere around 1 in 350. And as they age up into their 80s, it can even approach 1 in 200. Lastly, the use of azathioprine or Imuran can decrease the anticoagulation properties of warfarin. Now, often older patients can be on warfarin to prevent strokes, and this obviously has important clinical implications for the older patient population. All in all, I typically restrict my use of azathioprine in the older patient population, and if I am to continue using the therapy, it has to be after I've had an explicit discussion with the patient regarding the risks and benefits. The fourth medication we can talk about is methotrexate. Very briefly, methotrexate use in the older IBD patient population needs to take into consideration if the patients have pre-existing liver disease and or renal or kidney impairment. Now, why don't we talk about biologic therapies? The majority of evidence revolves around anti-TNF therapy. This includes therapies such as infliximab or Remicade, adalimumab or Humira, and golimumab or Simponi. And these therapies, when we decide to use in the older patient population, we need to be mindful of one comorbidity in particular, and that is congestive heart failure. A study has shown that a high dose of infliximab actually caused worsening heart failure in patients, and therefore, in the older patient population who has concerns with heart failure, we need to be cautious in that patient population. Also, along the lines of anti-TNF therapy, we look at the safety of the therapy, both from a real-world perspective and a clinical trial perspective. First, with respect to the real-world evidence, there's some older studies looking at Italian data. This was prospectively collected data in patients over age 65 on biologic. And it showed in that report that patients were at an increased risk of infection, increased risk of mortality, and even increased risk of neoplasm or cancer in this patient population. However, we also have data that looked at randomized controlled clinical trial data from the trials looking at infliximab or Remicade and golimumab or Simponi. And in that publication, what they showed actually was that there was a baseline elevation in adverse events in the older patient population, but there was no incremental risk in adverse events due to the anti-TNF therapy itself. So here we're again getting slightly conflicting stories. However, overall, I would say that the majority of the literature would suggest that the risk of infection on anti-TNF therapy is slightly higher in the older patient population. Now, with respect to the medications, vedolizumab or Entyvio and ustekinumab or Stelara, again, very limited data speaking to the safety in the older patient population. Overall, from what we know in terms of the mechanism of action and extrapolating from in ustekinumab from other disease entities and in vedolizumab from some of the smaller sort of retrospective studies that have been done, these biologics appear to be safe in the older patient population. And lastly, we can talk about tofacitinib or Xeljanz. And the one concern that came about within the last year relates to the risk of thrombosis or blood clot, more specifically pulmonary embolism or a clot in the lung. There was a registry looking at rheumatoid arthritis patients over age 50 with at least one risk factor for heart disease, and what they found that there was a slight signal suggesting that those in the higher dose, 10 milligram twice a day of tofacitinib or Xeljanz, were more likely to suffer from a lung clot or even death. Now, when we look at the IBD literature, just in all comers, not just older patients per se, but in all comers, we don't see necessarily a similar risk. However, that is something for us to be cautious about. There have been studies looking at this question, and one study looking at a large database of patients confirmed that yes, older patients do have increased risk of post-operative mortality, increased risk of post-operative complications, increased length of hospital stay, increased risk of needing a blood transfusion, increasing chance of cardiac, renal, neurological complications, and for the ulcerative colitis patients, an increased risk of infection, and for the older Crohn's patients, an increased risk of a blood clot. And so surgery is not taken lightly in the older patient population. Nevertheless, what I do want to stress is that if surgery is required, a timely referral to a surgeon is required. And once again, it's not only age or chronological age that matters, but it is really the concept of frailty.